All right, folks, we're going to come back together again to discuss the financing side, all the funding opportunities that are available. We're going to start off with PE. She's going to do an overview of the different funding opportunities available. Then we're going to move into Melissa on the implementation around the Tom Brown program, and then Monica Lasagna will come and speak to us about the CalMedForce program. So, turn it over to Kiki.
So when Natalie and I were designing the agenda, I virtually looked at her and said, we're putting finance in the afternoon after lunch. That never works. And I'll tell you that the two speakers after me will be far more interesting because they have money. I don't have money. Okay, so try and stay awake, please. Okay. Revenue. Let's just jump right in. The money side. So there's lots of different places to get money. Funny, I don't think I listed Tom Brown on there. Or CalMed. That's not because it's not there. Lots of places to get money. First, and the one that all of us think of usually first, is Medicare. Okay? And they train they provide funding for medical specialties, dentistry, and podiatry. Okay? Not nurse practitioners, not PAs, not anything else that might make sense, but this is what they train. Important is on Medicare Part B funds. And why that's important has to do with physicians and resident precepting requirements, which I don't plan to go into, but it is Medicare Part B. Medicaid also pays. It's not in our state. Okay? So, don't get that. We don't get Medicaid funding. But we do get Tom Brown and CalMed, so, it works. HRSA funds children's GME, and they also have the Teaching Health Center program. So let me just touch on the Teaching Health Center program for a second as to what we know about its status. Back in February a year ago, there was a budget administration bill that created continuation funding for the existing teaching health centers and funding for new teaching health centers. That bill or the funding all expires September 30th of this year. Now, this is the life cycle of teaching health centers. Did John, Kevin, they're gone? Okay. That's right, Kevin. Okay. So I have nobody to tell me. Kevin's gone, so he can't tell me I'm wrong. This is the life cycles of teaching health centers is they don't have 10 years of funding, right? So they're constantly on the cliff. And for a host of reasons that probably really don't matter, because the outcome's all that matters, HRSA decided that depending on the president's budget, which just got released, they may or may not put out an announcement in spring for funding on teaching health centers. That is not for the faint of heart, because if you go after that, it is with the understanding that you won't know until probably July if it was awarded, and it would be for residents that started July 1, right? And it's over, the funding's over by September 31st anyway. Now, why would you do it? You would do it to become one of the cohort of teaching health centers that lobby really hard and really loudly, and that both sides of the Hill or Congress like. Be part of that cohort, yeah.
Okay, so the funding opportunity comes out this spring?
Not definitely, maybe.
Maybe. It's awarded June or July for July residents?
Yes.
And it's over in September
Yes.
of this year?
Yes.
Why only 2 or 3 months?
Because that's all that's left in the funding.
But not your award.
The continuation, so there'll be a continuation bill.
Yeah.
I'm optimistic. I'm always optimistic about that.
Okay.
And if you're in that cohort, any continuation bill, well, there's different ones floating around right now, but in the continuation bill, there's no guarantee there'll be funding for new programs.
Right, so what you're saying will come out in the spring maybe is whatever money they have on hand now.
Right.
On the law. Right.
Right.
And hopefully they'll be refunded discretionary funding. And if they are, we may get another $100.
Well, if they are refunded with the provision for new teaching health centers. So we got to refund the existing
Yeah.
and add money for new.
They haven't added any new.
Right. What happened last February, not this past February, but the year before that, was the first time in however many years since 2010 that new was allowed. Okay, so, well, let me phrase that. The legislation went through that new was allowed. So the fact that there may be new is reason to jump in and try to get that funding, because then you're part of the group. However, priority is going to give to rural. Okay, and it's rural with the CMS definition. So, and they only plan to fund 2 or 3 of them. Okay, enough about that. VA. VA is the opportunity that a lot of us just keep forgetting about. Okay, Veterans Administration has money, and back in July, there was legislation that was passed that allowed for the VA funds to be spent on residency programs that's off their linoleum. Okay, what do we mean by off the linoleum? It means the residents don't ever have to even set foot in the VA. Okay? Now, that is still all being operationalized, and it's not anything that's going to cover 100% of the cost. For folks like, well, some of the folks in the room who are sitting with hospitals that are already capped and no choices, I'll take some money versus no money. Federally qualified health centers can get CMS direct TME funding. You can. But not if the hospital claims it. And most of you don't have a high enough Medicare percentage to make it worth your while. So you rarely do claim it. But in California, one of the other ways it works is like really cool. It's a rate-setting event. So if you've got an existing FQHC, you put a teaching program in, you can have that conversation about resetting your rate. Now, for some of you, that may not be a good thing. But for others of you, that might be a bump up. Only you can answer that.
You can, but you don't have to.
Correct. Correct. That teeny tiny pie chart, I don't know what it is. Maybe I don't know what it is. Anyway, it doesn't matter. That teeny tiny pie chart is meant to, which you cannot read at this point. I mean, I can't read it. It's meant to show you that the bulk of the funds, come from Medicare. It does. You fooled me. The bulk of the funds are Medicare. Billion, so 11.3 billion Medicare per stop, okay, which is children's and teaching health centers. Tiny, $500 million. I mean, $500 million sounds like a lot of money to me, but you know. VA 1.5 billion and Medicaid 4.3. So really, it's all still about Medicare. What Medicare pays? Medicare pays hospitals. Medicare does not pay consortiums. Medicare does not pay clinics except for direct, and it's not worth it for you to claim it. Medicare pays hospitals. Okay? So they pay a direct and they pay an indirect. And I'll go through with that history in just a second. The thinking about paying the direct is that Medicare, the indirect, is that Medicare only pays its fair share. Just like it does with everything else. We only pay our fair share. And so because of that, Medicare establishes what's called a per resident amount, and then it multiplies that by the Medicare utilization at that hospital. So if you're a place like Eisenhower Medical Center and has over 60% Medicare utilization, woohoo, this is good. Okay, because it's going to be the per resident amount, which I'll, for sake of argument, let's just say the 100,000, not that far off, times 60%. You're getting $60,000 in direct. That's amazing. If you're a county hospital, and you've got 3% Medicare, this ain't doing you any good. Now, where it's a heavy side, it's because of the language that the per resident amount is the lowest cost or the average in the PRAs in the area. I don't know, about 6-7 years ago, Medicare's cost or issue du jour was hospitals that might have randomly educated some resident, maybe without even knowing about it. Never claimed it on their cost report because it wasn't, anything they were going to ask for funding for. But Medicare said, you educated residents. It doesn't say if you educated residents got paid for it. It just says if you educated residents, then your PRA is the lower of cost, which your costs were zero because you didn't pay anything, or the average in the area. So they went through all these hospitals and said, guess what, your PRA is zero. Now 0 times whatever Medicare percentage is still 0. So there are hospitals all over the nation with a direct payment set in stone right now for 0.
Resident routine at hospital was report on Medicare spending report, and that's the medical cost report.
Yeah.
So where do they pull that data from?
Good question. How do they find out? If there are rotation schedules out there from other residency programs that show they were rotating at specific hospital facilities. If they can find things on the internet. That's how they find out. Okay?
They do that.
Oh. Yeah. Ultimately, anything on the Medicare cost, ultimately on a GME perspective, it says in the Federal Register that it is the CEO's responsibility to decide whether they think the hospital is eligible for direct and indirect. That any information you get from the MAC, the intermediary, or CMS, hey, that's fine and good, but it's still the CEO's responsibility, which puts all risk on the hospital should the MAC, usually it's the MAC, or CMS come back and say, no, we're not allowing that. This is a real issue because up until this point, particularly in smaller hospitals, we'd send residents everywhere all the time, right? Okay. Indirect medical is a function of your resident to bed ratio. It's actually intern and resident to bed ratio. And Medicare percentage at the inpatient facility. Physical location matters. Okay, so for example, if you are doing didactic, you're doing lectures at a clinic that the hospital does not own, and isn't on hospital license base, that rotation does not count. Okay, so when you're going half day by half day and counting your total FTEs to get paid, guess what? Every Wednesday afternoon for all your residents isn't counting. There's other examples like that. We don't have the time for me to go through multiple examples. The bottom line is, they're going to look for how do they not pay for this. So you got to have a cost report person in your pocket, and not to insult all the program directors or wannabe program directors or friends of program directors here, but the program directors usually aren't focusing on this issue when they're setting up their curriculum, which gets the CFO mad at them. Here's in training matter. Does the resident have advanced standing? Okay, and the type of training. So not that this has ever happened, well, I'm sure maybe happened somewhere, but if I start a family medicine program and then go, golly gee, I really want to be a surgeon. Yeah, I know. How often does that happen? But I'm going from a 3-year program to a 5-year program, but because my initial training was 3 years, or for a 3-year program, all the GME the hospital will ever get is 3 years for me. Okay, so that's all kinds of crazy rules here. Quick history. Let's see. I have another. Okay. I know I have another. Oh, there it is. There's the part. Never mind. Okay. 1965, Medicaid and Medicare were passed, right, and implemented. That's when we created GME, the direct part. And it was Medicare's plan to pay that direct cost only till community could take that back on again. Okay? And that's really when we went from the cottage type of industry of training folks mentoring where I would go be at a hospital, hang out with a physician, live at the hospital, get room and board in exchange, to a more formal medical education model. Okay? 1982, right before we implemented DRGs, we created indirect. And indirect was created to pay for the additional cost of training that a hospital incurs by having residents. Oh, they run more tests. Oh, they run more labs. Oh, they fill in the blank. But the fact is, when we implemented prospective payment system and diagnostic-related groups back in 1984, that kind of flies out the window, right? So now we're getting case rate for the care. But hospital CEOs hold on to that one anyway. And if you look at the literature, I actually had a hospital come, their cost report consultant come at me and say the hospital is going to retain 40% of the IME and not pass it through to the FQHC because of the additional costs the hospital incurs. And after I finished a few profanities, I told them to go, I cited a few articles in the literature and said, you need to go update your reading and update your CFO and CEO, because in family medicine, that is not good. And all you're doing is trying to keep the FQHC from having money that they need to train each other. Ooh, there's math. Okay, I just show that to show, here's a formula. And you run numbers through your cost report. The most common mistake I find in starting new programs are hospital folks who say, oh, we're going to have 18 total residents. Let me run the formula based on 18 residents. Boom, here's what we're getting. And it's not that way. You must figure out the block rotation schedule first. How many residents are really going to be rotating through that hospital before you can run the calculation? Anytime you send those residents out, they need inpatient peds and peds ER in family medicine. And it's a really hard one to get at a community hospital. You're now sending them to children's hospitals. That's great. You've now lost your revenue for that rotation. You still have to do it, but you've got to factor that into your financials. My favorite one is let's send all our residents to a mandatory 1-month rotation in pick the foreign country outside the U.S. Do you think Medicare pays for training in another country? No. Okay, so these are things, if I were to put on my hospital CFO hat for a minute, they really care about, and we need you guys to care about too. All right, I'm going to skip the rest of the formula, except to say, isn't that fun? You've heard us mention GME cap. In 1997, after the Council on Graduate Medical Education came out and said, oh my God, we have too many residents, we have too many physicians, we have a glut, the Fed said, okay, we're going to put a cap on it. And we will only pay you for the FTEs that you had on your 1996 cost report. There are a limited number of ways that you can increase the cap. Okay. One of them is if you have a cap of 0. So in 1996, there were no residents training at your facility. You have a cap of 0. Now, as Ellen can attest over there, there's some hospitals who have a direct cap of 0 and an indirect cap of what, 0.58 or 1 point something or something ridiculous. Okay. All right. But that's what we talk about local virgin hospitals, politically correct school, GME naive hospitals. And if you're GME naive, then you have a cap of 0. And then we have to ask, do you have residents rotating through at all? See if their PRA has been set at 0. And if I get cap of 0 and PRA not 0, then I know I have an opportunity to trigger a new program. The only way I can grow their cap is if I've got a brand new program. Okay. Other ways to grow cap. Affiliated groups. You've got a program. I'll give you an example. In the Denver marketplace, HCA purchased a hospital there and decided to close the family medicine residency program, bringing out X amount of cap. I don't even know. To the best of my knowledge, they are not putting in any other residency program, so now they can affiliate on an annual basis those slots to any other one of their HCA hospitals. To mention new programs, rural hospitals and rural programs. Those of you in rural, 10 minutes. Okay, there's some opportunity there. You can grow the urban cap and have the rural. Okay. We kind of did that. You have 5 years with a new program to set the cap. Okay, and that is something you do very consciously plan for. And then I duct tape residents into their chairs so that everything is counted. Teaching Health Center, we mentioned that briefly. That's a very distorted map, but that's where the teaching health centers are currently, except for maybe some of them are closed. I'm going to skip all of the rest except to say that we did a study by I mean George Washington and the university and myself, funded by HRSA, on what is the cost of training teaching health center residents. You will hear a magic number given all the time by $1,000 to train a resident. Yeah, but first of all, that's 2017 numbers, so it needs to be adjusted up. Second of all, it was for a cohort of, it was a snapshot in time in 2013-14, of which only 26 had clean data. I'm not saying the study is flawed at all. I'm just saying take into consideration the context. Okay? New programs cost a lot more. And the thing that I think is the coolest of all of it is that we took out, we factored in clinic revenue and clinic expense, which is something CMS does not do. But the argument I made is, who else gets the grant, gets to generate revenue off of it and not count it. Okay? So, depending on whether you're a brand new program or not, and have a clinical foundation to work with, if you have inpatient volume to work with, all of that varies with your number. Also varies what your CPS rate is. Okay, programs that are upside down, every patient they lose money, and no, I do not factor your 330 grand into this calculation. Okay, so every patient, every encounter they see is upside down. Lo and behold, take on a residency program, assume incremental volume, and you're going to lose more money. Right? The plan being here that when we take a look at this and we show how much money you're going to be losing, to have a discussion with the hospital partner about them paying that through a community benefit program. Okay, because you can't be negatively financially impacted by taking on this residency program. This is straight out of the financial tool that we designed that was OMB approved. There is no, why show it is there is no standardized general ledger chart of accounts as to residency financials anywhere in the nation. Okay. You have, other than this, is something that's done by the National Institute of Program Director Development. So I show this to give you a sense of some of the categories, both of revenue, and then we're going to get, that's really tiny print, but you got the handout of expense. We break it down in buckets. What is the clinical revenue expense? What is the academic revenue expense? Precepting and non-precepting clinical. Okay? And with my firm, we've evolved, this is something we don't use. We actually run it through your cost report to see what the impact is. Okay? As far as THC or CMS, I hit on it a little bit. I want to drive home one thing. If you are talking to a GME naive hospital, do not put a teaching health center there, because that's considered double dipping. And all you're doing is triggering care per resident amount on Medicare while you're getting funding from HRSA. Okay, so let me walk through that again. If I'm a THC fund, $150,000, and I step foot and go get educated in Main Street Hospital that's GME naive, unless Main Street Hospital pays for the cost of teaching, their PRA is going to be set at 0. They'll get direct dollars of 0. Okay, fine, we'll pay the teaching. Well, you can't claim it on that cost report and put it to her. So if you are a THC program, or plan to be a THC program, stay away from a GME naive hospital. Another thing to look at, THC versus CMS. Why I love teaching health centers for a lot of reasons. But one of them is there's none of this funny business of that rotation counts and that rotation doesn't, and that one has a van standing, and that you get $150,000 no matter where they train, even if they go out of the country. Right? You don't have to twist yourself into pretzels figuring out how you're going to make the curriculum work in order for the hospital to get money. And it's not that the hospital be mean and evil. You want that money because you want to be able to train your residents. You don't want to be always arguing for a budget shortfall. Yeah.
What do they typically fund? Like if you have a 666 program, do they fund out 6 typically or just a portion?
No. CMS never funds the full amount. Hey, they will. Whatever you ask for, assuming they've got the funding. If you ask for 666, you get 666, assuming they have the funding, which in the past they always did. But this go around, they no. This go around will be a competitive process, whereas in the past it wasn't. Who was asking? This is startup costs. Have you look at that on your own for 10 minutes. I want to hit up another thing. What does all this mean to you? You have losses due to inefficiency and lost capacity. However, that is a function of three things. One, what year resident you have. If you have first-year residents, you will lose money. Because in the beginning, they see 1 patient per hour. Okay? But by the end of year 2, if you have the throughput you should have for at first expects you to see, you should be making a little bit of money or at least be budget neutral. And by year 3, you should be making money. Now the only thing that varies with that is what your normal throughput is. Because if you've got faculty who sees 8 patients a half day, there's no way, the residents most ever going to be seeing as 8 patients a half day. But if you've got faculty who see more than that, okay. And then your reimbursement rate. And if you're getting $89 per visit, it's really hard to make money on that. Okay? So that's the takeaway. Opportunity costs are there. You will spend a fair amount of time managing this program. And then you can always get, and we should talk about foundation support, or government support, which might well be my lead-in into our are you up next, Melissa? Or yes. Okay. Okay. That was like really high-level finance. Really high level.
So, yes, we'll transition it over to Melissa. She's the Songs Brown manager, right, at Oshped. Has been working with the Songs Brown program. She's a great resource to you all and has been with CPCA. She does need to get going after her presentation, so we're going to do Q&A right after hers before we move on to PhD. Just as a heads up.
Thank you. Okay, so today I'm here to talk to you about a funding, a residency funding option that you have in the Songs Brown program. How do I work? So, right? Okay. All right. So the Songs Brown program is a statutorily mandated program. It is covered by Health and Safety Code that is listed here on the slide. And as a statutorily mandated program, we must consider statutory priorities when considering what programs we are going to fund. So statutory priorities being clinical training sites in areas of unmet need. We want to see that you are providing your residents with experience and exposure to underserved populations in what we consider to be areas of unmet need. The second one is placement of graduates in areas of unmet need. We want to see that in as much as possible, your graduates are going on to work in California areas of unmet need as well. And recruitment of underrepresented minorities. We again want to see that you are producing diverse residents to go back and serve the communities in which they came from. Songground's focus is primary care. We award family medicine, primary care, that being internal medicine, obstetrics, and pediatrics programs, as well as family nurse practitioner, physician assistant programs, and registered nurse programs. We do all of this work in collaboration with the California Healthcare Workforce Policy Commission. We are a 15-member advisory body that sets policy and recommends awards back to the Songground program. So Songground is a competitive process. I just want you to keep that in mind as you work through and decide if you're going to come to Songground for funding. The program is set up by funding categories. We don't have a particular dollar set aside for internal, family medicine. It's set up as categories of funding that you may apply for. So the definitions of these are: an existing primary care residency program is one that is accredited by the ACGME and will enroll at least one class by July 1st. A teaching health nurse is a community-based ambulatory patient care center operating a primary care residency program, and you can see all of the different types of centers that are included in that definition. Primary care expansion dollars are for those programs that have decided to permanently expand the number of staff. In order to apply for expansion dollars, you must have a letter from the ACGME granting you the authority to expand your program. That is a requirement. And then we have new programs funding. New programs funding is what I imagine most of you would probably apply for the first time that you would come to Songground. And that is for residency programs that will receive their residency accreditation after July 1 of 2016, which I imagine is probably all of you. You have not enrolled your first cohort, and you have not received any prior Songground funding. So the dollars available for each of these categories, Songground for the 1920 fiscal year has $31 million to give to residency programs. The way that breaks down is for existing slot funding, we have $18.7 million. That is spread over 3 years for at least one resident of the program. You will receive $125,000 per filled first-year slot up to a maximum of 5 residents. There are no indirect costs allowed with this funding, and you need quarterly in arrears. So you will let us know, you will start your program, you will train your first residents, and at each quarter you will submit documentation back to us showing us that you have trained these residents, and then we will pay you some of the dollars. Teaching health centers, there is $5.7 million available. For teaching health centers, you are allowed to request $170,000 per filled first-year slot. For this particular bucket of money, there is no maximum on the number of slots that you can request. So if you happen to be in 10-10-10, you can ask for money up for those 10 residents. Excuse me. And the way that on this particular award, you are allowed indirect costs. And for this award, you also will be paid 70% of the dollars up front. Once you've signed into an agreement with us, we're going to pay you 70% of the dollars, and the remainder will be paid at the end of the term. Expansion slots,
There's $3.3 million available for that. Again, that's for programs that are permanently expanding. You are allowed $300,000 per first year slot, a maximum of 3 slots. That also is paid quarterly in arrears. New programs, $3.3 million is available, and these funds are really to offset the cost of becoming accredited. You can request up to $800,000. And the way that you get paid in this particular situation is you have to become, we're going to award you, but you have to become accredited before we actually give you the money. So to receive your residency accreditation, you submit along with proof of the and then so this slide right here just kind of shows you how you can apply for dollars with the Song Brown program. As a new program, the first time that you come to us, if you want to apply for new program funding, that's all that you can ask. That's a one-time funding opportunity. And if you come back again, you can now apply as an existing program because hopefully you will have enrolled your first student. And the plus, if you're a teaching health center also, you can also ask for teaching health center funds. And then if you just happen to be expanding, you can also ask for those funds. So there's opportunity here for you to be able to ask for more than one pot of money. All right, and this last slide here, oops, I don't know what happened there, just shows that since 2013, Song Brown has awarded, and I think that the numbers in there were 20, 28 or 24? 4%. Yeah, so it's 20. Has awarded almost $21 million to teaching health centers out of $88 million, or a total of approximately 24%. 24% of all of those awards have gone to teaching health centers. Let's see. So just to kind of wrap it up, Song Brown funds institutions that train primary care health professionals to provide health care in medically underserved areas. I think that's what a lot of this talk has been about today. Certainly teaching health centers align with Song Brown mission. There is approximately $31 million in state funding available in 1920, and the fiscal year 1920 governor's budget proposes a permanent allocation of $31 million for Song Brown. Right now, we are at the tail end. In 1920, is the tail end of the 3-year appropriation. The Song Brown governor is proposing a permanent allocation of these dollars. And our application cycle opens at the end of April, April 30th. So I am always available if you have any questions. The Song Brown at Oshkosh, that's our general email account. And then you can go out to our website to get additional information about the Song Brown program. And I also have cards available if anyone is interested. Hi.
I was just wondering if an existing teaching health center wants to expand, are they applying under teaching health center just with an increased number, or are they applying as expansion slot?
So an existing teaching health center would apply for teaching health center funding, and then they also could apply under expansion slot funding.
Okay, thank you. You're welcome.
And existing also, yes. All three. Hi.
So can you share a little bit about the review process?
Yes. So when I talked about the priorities for Song Brown, I talked about providing training in areas of unmet need, providing graduates in areas of unmet need, or placing your graduates in areas of unmet need, and having underrepresented minorities in your program. So what that means for Song Brown is each time you apply, you are going to tell us where your training sites are located, physically located. We need their name and their address. We need the name and the address of when your graduates go on to practice. Once you eventually have graduates, you're going to tell us where they're working at today.
not where they were working at, 2 years ago, but where they're working at today. And you're also going to provide us with the race ethnicity of each of your students and graduates. What happens then is we have a system, it's a geo system that looks at the addresses and determines if that address is actually located in what we consider to be an area of unmet need. And so for each address that is located in an area of unmet need, you get a point, per se. We'll just call it a point. And then at the end, there's this whole other bell curve percentage score that you get out of that. And then your final score, you're, of course, ranked against all of the other programs that applied for those same dollars. And the commission, all of that information is given to our commission, and the commission takes all of that into account when determining who's going to receive the funding.
Does it kind of correlate with the scholarship, the National Health Corps, the underserved population? They have a scoring system.
Yeah, well, for Song Brown, what we consider to be an area of unmet need is any address that's located in a medically underserved area, a medically underserved population, and the commission has its own designation for what they consider to be an area of unmet need, which is called a primary care shortage area. So each address that is physically located in one of those areas receives, I want to say, a point. Hi.
So how long do you have to be reporting where your graduates work and live?
Yes. So right now we're asking programs to report 5 years worth of data. New programs, of course, you don't have any data to provide. You have a more qualitative type application that you're going to fill out if you're applying for new programs funding. So your application is going to really look like, tell us what you're going to do. You may not be doing it right now, but tell us what you're going to be doing.
But after that, someone has to go around checking every single one of those graduates.
Yes, it's labor intensive. You need to know where your graduates are going if you want to. Yeah.
And they need to, send you back the information. Just
Right.
Having applied for this grant multiple.
And they're going around
It's
check
hard.
that information, do they verify it?
I think I mentioned earlier that we are now have started program review. So we have hired a consulting firm that will go out, and if you happen to receive funding, and they will kind of will site visit.
So that was my next question.
Yeah.
Do you have site visits?
We do now. In the past, Kelly can attest to, I think, that our site visits were more friendly. But as of right now, we do have a consulting firm that is doing that is looking at each of your applications and reaching out to the programs and getting information that backs up what you have put in your application. Yeah. Hi.
Looking at the 2018 awards, it seems like, there's a lot of programs that meet these requirements that weren't awarded. Is part of that just the scope of the application that people don't take the time to fill out and apply for funds?
That didn't receive funding?
It looks like it's trying to apply, I guess, or it's one designated fund.
Yeah, so it's, like I said, it's competitive, and right now the commission, there's a total, I think, of 100, if it's 100 or 115 points per application, and so the commission has determined you have to meet the 50% mark to even be considered for funding.
I just want to add also, not only all these awesome requirements, it actually made us, in recruitment, I think one of the earlier speakers said it's hard for FQHCs to be at the table, but if you're looking at $600,000, for 3 residents, then you can tell them, hey, we want to recruit people who, look like our community.
Right.
Who are, in this underrepresented minorities, and we want to train at these sites. So that can be a way that the FQHC can really kind of push that. So we actually changed one of our, and there's onboarding, but, what is your cultural background? And so that's one thing. The other is part of the application is also team-based care.
Yes.
It's, are you working with community docs? So it's not just, so it actually is, I love this grant, because it is jumping out of the academic, it's just a bunch of research. No, you're working with family docs all over the place when you're an FWC. And so it does help to not only, hey, if you get the grant one time, you can kind of push and say, we could get more money, and that's kind of what I did. I think I was way down, and then I, knew how to talk to the leadership at the hospital. I will also say that if you're a sponsoring institution, you get the money.
Mm-hmm.
And so if you're not a sponsoring institution, then they get the money. So not only we would get the money, but then we'd have to say, hey, this needs to go to the residency program. And so there's some stuff like that. Yeah.
So, and I really want to encourage all of you, if you're thinking about starting a residency program, but you're not quite there yet, and you're thinking that you might be interested in applying for some grant funding, to come out to one of our meetings. They're all public meetings. Like I said, our application, the next round goes out at the end of April. So if that's not something that you're able to do, but you're still thinking about Song Brown as a possibility, those applications will be seen by the commission in August. So if you wonder, you can see when the next commission meeting is, where all of the applications that are received in April will be heard by the commission, or seen by the commission, actually. Huh? Yeah, in August they will be awarded. Right. Yes.
I don't know why I'm confused on the teaching health center definition versus new program. Are they just, they can be mutually exclusive, or are they?
Yes. Well, yeah.
Are they to start as a new program and become a teaching health center?
Well, the first year of funding, this funding that we had, at that time, if you had applied then, you could apply for, teaching health center and new programs funding at the same time. But the commission stopped that after the first year. So now you have to make the choice. Do you want to apply as a new program, or do you want to apply as a teaching health center? So if you your accreditation at the time of application, then, and you're a teaching health center, then you would go the teaching health center way. If you don't have your accreditation yet, then you apply for new programs. Yeah. Any other questions? No? Thank you, Melissa. With the position for a healthy California. As you may know, they just created the CalMedForce program as a result of new Hot community dollars that were available in the last year. So we're going to call you guys here to share a little bit about their program.
All right. Hello, everyone. I know it's nearing the end of the day, but I hope you're still with me. Please ask questions while I'm going through if you have any. All right. So I want to start with background of PhD, CalMedForce, eligibility. Because, of course, I'm sure you're wondering, who is PhD? Why are they giving money to residency programs? So I'm going to go over that background a little bit with you. So Physicians for Healthy California, we are a nonprofit, a 501(c)(3). We actually were formerly known as the California Medical Association Foundation. So you might be familiar with us there. We did some rebranding recently, so we are Physicians for a Healthy California. And essentially our mission, really at PhD, we're dedicated to improving community health, growing a diverse physician workforce, and promoting health equity. And PhD has really evolved over the past few decades. And just to give you a little preview of what the programs we actually are involved in, of course, CalMedForce, the GME grant program, the loan repayment program, which I'll actually talk about at the very end, Cal Health Cares. This is very new things. We still have yet to really publicly release the name of the loan repayment program. And then we also have Network of Ethnic Physician Organizations, NEPO, in which we have a coalition of ethnic physician organizations in California working to decrease health disparities and increase cultural competency in clinical care. We also have AWARE, and so we have various programs. We're continuously evolving, but want to talk to you today about CalMedForce. So in 2016, I'm sure that you all voted in the vote for Prop 56, which is the tobacco tax. So this was approved by voters and really allocates $40 million towards GME. So in the statute, I will often refer to sustain, retain, and expand California residency positions in primary care and emergency medicine. So definitely want to point out here that this is a point that separates us from on-ground funding, and that we fund emergency medicine. This is in the statute for our program. And the statute that we do have, there's only a few, and that's actually on a next slide, but we really have worked with the board, the advisory council, to really figure out what is our grant eligibility criteria, the administration, lots of different items. So we have an advisory council, we also have a board as well, and again, important to note that we are contracted out with the University of California. So in statute, $40 million was given to UC. UC in turn contracted with PHC to administer this money. So at the end of the day, it is really UC that was awarded this money. And then the advisory council, we have a 15-member advisory council here, various members, and we also have CPCA on here. So I've definitely worked with Natalie, subject matter expert, who is on our advisory council. We also have a board as well with various organizations. And here's the statute that we often refer to, really focusing on, there's only a few lines that really describe our program. And so from these few lines, we've had to start from the ground up. So when we're looking at what is CalMedForce, what do we stand for, we're always looking at how do we sustain, retain, and expand GME programs in California. Along with our priorities focused on, we want to really give the money to programs to areas and populations. That is a main priority for us. So the mission we have, again, going back to what we stand for, we're really committed to growing a diverse physician workforce by supporting, incentivizing, and expanding GME in California. Our goal is to grow and strengthen physician pipeline to meet the demands of California's growing patient population with a focus on medically underserved areas and populations. We are evolving. We are quickly changing. At the bottom here, we have just a very general timeline to give you an idea. We really began this program in August of 2018. We released our first application December 12th. We had turned around, we closed the application mid-January. We made award announcements at the end of January. And this is really an evolving program. And the great piece that I really enjoy being a part of this program is that I get on the phone with program directors, I hear their feedback, we like the application, we didn't like the application, we really enjoyed this question, or actually potentially think about wording it this way. We very much take all feedback so that we can ensure that at the end of the day, the application is an easy process, that we have taken into account the various nuances with all residency programs. So we definitely, we changed the program, we changed the application based on feedback from people. So we were looking at four criteria. So the next few slides I'm going to go over really what our program has done. But definitely want to note for you that there's going to be differences in funding structures. We're looking through figuring out what is our award criteria for this upcoming cycle. How is that going to change? So I'm going to go through what we have now. Currently, an eligible residency program is located in California, primary care, emergency medicine, accredited, and then also, of course, again, it's about continue serving medically underserved populations and areas. So this, in a nutshell, this is the eligibility for the residency program. And again, the underserved areas and populations. We want to know, who are you serving? For past applications, we were asking what the payer mix look like for your continuity site or site in which residents are training. We really wanted to understand who is it that they are serving. And of course, with the where are you serving, similar to what Melissa had mentioned, talking about HPSA score. We were concerned with really figuring out, how do we know medically underserved area. So we were looking at HPSA score, as well as giving points to really figuring out what was a priority county for us, if you will. So we had a list of counties in California that if you were practicing in one of those, you received extra points. So we are quickly trying to figure out, how do we really ask this for the upcoming application cycle. So instead of just asking for HPSA and looking at priority counties, how can we really understand this? So this is what we have for the application cycle, and we're still going to dive into this a little bit to make sure that we ask this question in a way that captures different nuances within different specialties. Another piece that we really are focused on is the sustain, retain, and expand. So we have given priority to the programs that are expanding. So this will continue, in which we want to a grant. We want to grant you money. So that's the good news, right? So we want to that, we are already facing a physician shortage. We all know that. But we want to really work with you, partner, and figure out, how can we flip this? How can we change this? So we will be continuously supporting and prioritizing new programs, especially programs that are expanding. So again, the funding. So this is the funding for this previous application cycle. This is broken down by discipline. So family medicine, we have 1.5 million, internal medicine 7.6, OBGYN 5.7, PEDS 7.6, and emergency medicine 7.6. Put on here that these funding amounts will most likely vary. There are going to be decisions that are going to be made in the next few months by the advisory council, the board, in which we may actually have everyone competing against one another. That's an open item. We're still not entirely sure exactly where we're going in that direction for the next application cycle. But I know that once this information is released, we'll be sharing this on our website. And of course, Natalie will be a great resource, as she is the SME on the advisory council. So the funding structure for this past cycle, funding was really available to me. It's a very broad term, in which we recognize that when we released the option, in which we were getting a lot of calls asking about, what about simulation labs? What about faculty development? And so we have recognized that there are a lot of items that could be a direct GME cost. And so because our program is so new, we're actually still working with UC on making a more exhaustive document and really laying out clearly what's allowable and what's not. But at the end of the day, we do want to ensure that these funds are used for direct GME costs. So for faculty development, for recruitment costs, we understand that these do fall under direct GME costs. So when looking at the funding structure a little bit more, we definitely have a very different funding structure from Stone Brown. The way in which we talk about funding is per resident. So when we looked at how much it actually amounted to fund a resident per year, we looked at the number that Kiki had provided, 157. And we said, all right, this is about average. If we cut this in half, 75,000 per resident, we can ensure that we have good buy-in from the actual sponsoring institutions, and also this could be a large amount to actually help residency programs in general. So we talk about $75,000 per resident each year for the duration of the residency program, so 3 or 4 years. And so residency programs, they can request up to 5 residency positions. So award ranges were varied, anywhere from $225,000 to $1.5 million. Again, this is an item that we are thinking of changing, trying to figure out, do we award more per resident? Do we award less per resident? So this is an item, again, that we will be figuring out for the next application cycle. Process for determining award. Because we had such a quick turnaround, we made sure that this was something that could be auto-scored, really based on the application that the advisory council and the board and the UC that we all decided upon to really get these dollars out the door as quickly as possible. So the applications were auto-scored. There were no narrative questions. I do want to note that we are thinking of adding in narrative questions for this next application cycle. So for this past cycle, the way that we actually awarded was based on a tiered system. Essentially, the highest scoring applicants in each specialty received the most amount of funding. Again, process will likely change for the next application cycle. But we will always ensure that it is a transparent and clear process, because at the end of the day, we know that you are the applicant. We want to ensure that you can be successful in filling out the application and that you know what it is that we're scoring for. So looking at the grand summary, we had an amazing turnout, 131 applications. 131 applications requesting $147 million. We only had 38 plus some change to award. So that, I know these are a lot of numbers and it's really late, but I want to just really highlight family medicine. There was a very large turnout in family medicine. It is very competitive, but again, we are prioritizing new programs. We want to really add more primary care physicians to the state of California. So we will continuously prioritize new programs and programs that are expanding. So I just definitely want to put that plug in. If you're thinking of starting a residency program, you already would be given priority essentially in the process. When we look at who was actually awarded, we had a total of 73 programs, which was amazing because, as you can see, it really is all across California. The different colors denote different specialties. A little difficult to see. But the main point that I want you to take from this slide is that we are funding programs that are in urban areas, that are in rural areas, and we are definitely focused on really adding physicians. And when we look at community health centers, here is actually was awarded this past year, which was a total of $2.7 million. So that was great. We were so glad to be able to send those checks out. The big key highlights, really CalMedForce annual grant program supported by tobacco tax. But we are evolving. It's an annual, but the piece I definitely want to put the plug in is, if you are thinking of starting a program, we would love to have a conversation with you, really understand what it is that you may need, how can we help in some way. Of course, the grant program itself is only eligible if you're accredited, but we of course, we want to start collaborating in the beginning. How can we start to help you even before that point? We have $38 million in funding each year. And again, the funds can range, and new programs expanded. We're always going to prioritize those. The next application cycle will be in early, around August, September. we already thinking about potentially making the award announcements in November. So we will be really maybe doing it in the next couple of weeks as far as what this looks like. You can look at our PhD website for more information, or of course connect with us on LinkedIn, Twitter, subscribe to email updates, and we also have a number here as well. And it's not an automated line. There is a real person on the other end. We will answer. So before I get into the loan or payment piece, I want to ask, are there any questions right now? So no, it's everyone. So even if you did receive funding in the first application cycle, you're eligible again. So you did not. That's a great question. That piece is actually still being worked out with UC because the award contract. There are some pieces that still need to be finalized, so it can be right now. We're hoping that it can be someday the revenue grant that really decides which one is the entity that's awarded. But it's still a fine thing to be decided. Are there any other questions? All right, so I'm assuming that you all understood that really well and that you're going to come and talk to me later about how can I personally. All right, so the loan or payment program. So I will.
I do actually have a question.
Yeah.
Where will the application be available?
Online, so it'll be on our website. Okay. Yes. Yeah, we do not allow any mail-ins. We're trying to jump into the 21st century. Yeah, so we have 6 webinars for the application cycle. We are very service-oriented in that regard. We want to ensure to jump on the phone with you, the application itself. We actually, for this upcoming cycle, we plan on having pre-application webinars. So before the application is even released, just talking to everyone about what are we prioritizing, sort of giving them a preview of the application, if you will, before the application is released. So the other piece, partner together to really run the loaner payment program. So I do not oversee the loaner payment program. Definitely want to broadcast this for you to take back with your stakeholders. So DHCS, of course, Department of Healthcare Services, they oversee CalHealthcare's program. Similar to CalMedForce, the money was awarded to DHCS, and PHC is administering the loaner payment program. Again, so we have an advisory council that's really providing expertise and advice for the loaner payment program. There's 15-member advisory group here to the budget act. So again, it's Prop 56 money, $220 million. So this is going towards the loaner payment program, and this is, here's the statute that I talked about, loaner payment program, and the tax is very small, so I'm going to run this to get to the bigger item, which is eligible physicians and dentists may actually receive a payment of up to $300,000 in exchange for a 5-year service application. And so this is a new loaner payment program. This application we were just awarded this money through DHCS. I believe it was about a couple months ago. So there is still a lot of work to be done, but we're working to ensure that we can get money out to physicians and dentists because the important piece here is that awardees are required to maintain an individual direct patient caseload of 30% or more Medi-Cal. So that's, yeah.
In the first 5 years post-training, right?
Yes. Yeah. So there is, yes, thank you for bringing that up. It's definitely focused on physicians who are new into the workforce. We are focused on that population there. Also, this specifically for there is a grant program in which they can apply up to $300,000 to actually relocate to a targeted geographic area in exchange for a service commitment. So this is definitely a piece in which it's a smaller amount of money, in total for $20 million, still the same amount for an eligible center. So, so hopefully, if you're interested, I don't believe we've even posted this on the website yet. So this is definitely an item that you can take back and say, hey, I went to this amazing criteria. Is really that an applicant has to have an unrestricted license, standing. When looking through these criteria, they're going to make sure a lot of physicians could actually be eligible. And so definitely encourage to send them on to take this. This is really an important piece about retaining of overall of PhDs. There will also be a webinar in the next few weeks going over how to build this application. We will make a award application on June 3rd, and of course you can go to our PhD website, healthcare, phd.com. This is PhD. I've been on an program, of course I have a program analyst, and then also on the other side of PhD we have healthcare, loan repayment program. And our leader, Lupe Alonso, for the CEO, is unable to be here, but at any point you have any questions about PhD, loan repayment program, the Jamie program, we want to hear from you. So